Hello friends, welcome back to my channel with a new video, and this is the part 3 of the series of overview on acute pancreatitis. And if I may request you all to like and share and subscribe my channel. So without further ado, let us start with this part. And the last time we discussed about the crystalloids and the emphasis which is put on the balanced salt solutions. Just a bit on colloids, whether there is any role. So the use of colloids, including the semi-synthetic colloids, that is the hydroxyethyl starch or gelatin and dextran solutions, and of course the natural colloids in the form of human albumin is not recommended because of the potential adverse effects without a demonstrable survival benefit. It is not recommended. So this is the message. Now, if you talk about the crystalloids, then these are all the recent the randomized controlled trials. And how much is the question? So, with a Matto et al. In 2009, studied 10 to 15 ml per kg per hour versus 5 to 10 ml per kg per hour, and it was found to be harmful with more sepsis and mortality, mechanical ventilation in aggressive resuscitation. So probably it is on a lesser side. Wu et al. In 2011 again kind of compared the goal directed therapy, the 20 ml per kg bolus followed by 1.3, 1.5 to 3 ml per kg per hour of uh, ringer lactate or normal saline versus ringer lactate or normal saline adjusted by the physicians. Buxbaum in 2011 studied about 60 odd patients with 20 ml per kg bolus followed over 2 hours followed by 3 ml per kg per hour of infusion versus 10 ml per kg bolus and then 1.5 ml per kg per hour of infusion. And what he found was there was less persistent SIRS and hemoconcentration in aggressive resuscitation at any point of time. And Celar Monterrubio et al. In 2020 with 88 patients compared 20 ml per kg bolus followed by 3 ml per kg per hour and 20 ml per kg bolus followed by 1.5 ml per kg per hour, and they found that there is no benefit or no difference in uh, occurrence of SIRS or pancreatic necrosis and respiratory complications. So these are few of the trials and studies for the students who are appearing for the exams. And this is a research summary for the aggressive or the moderate fluid resuscitation in acute pancreatitis published in NEJM in 2022, and it talks about the conclusion in the form of amongst the patients with acute pancreatitis, early aggressive fluid resuscitation did not lead to a lower risk of moderately severe or severe acute pancreatitis than moderate fluid resuscitation and was associated with an increase in the risk of fluid overload. So overall the messages are towards restrictive side, towards a less liberal side for the IV fluids, and we'll also discuss this in the summary. As I said, how much fluid? So for mild acute pancreatitis, the initial resuscitation rate of about 1.5 ml per kg per hour with the bolus of about 10 ml per kg if the hypovolemia is in the first 12 to 24 hours. And of course, there's close observation, monitoring, reassessment about the fluid overload, do the POCUS, examine the patient clinically on a frequent basis and have a caution in the patients who have underlying cardiac and renal diseases. In the MAP, if early moderately aggressive intravenous hydration is not provided, the disease progresses as the BUN and of course the hematocrit will rise during the first 24 to 36 hours. And once the patient has a severe disease, then there is no benefit of early aggressive hydration. So with a severe disease, there is less emphasis on the aggressive hydration. In fact, it can be more harmful. and you need to actually individualize the case. One cap does not fit all, and that is the principle probably across the board which is applied in critical care. So, goal directed therapy, the titration of IV fluids according to the specific clinical and the biochemical targets, including the heart rate, the mean arterial pressure, the CVP, urine output, BUN, hematocrit, lactates. And as I said, it's a structured approach and the individual approach rather than, one particular approach for everyone. Uh, so the SAP, or the severe acute pancreatitis, where there is a persistent organ failure and markedly increase in the vascular permeability, more and more IV fluids in these kind of patients will worsen the disease. So mind you, clinical endpoints that could guide fluid resuscitation in the patients with SAP are classified in three groups. So non-invasive clinical parameters, invasive hemodynamic parameters, and laboratory markers. Okay, so these are the clinical parameters where we commonly monitor MAP, the heart rate, the urine output, and capillary refill time. So tachycardia of say about 120, MAP of between 65 to 75, maybe even 85. Urine output should be more than 0.5 ml per kg per hour, and these are the desirable endpoints in the management of severe acute pancreatitis. And abnormal values alone or with other signs of organ hypoperfusion, which suggest a prompt fluid administration. What about invasive hemodynamic monitoring? So, of course, CVP and the SCVO2 will help us a bit. Arterial line, I would probably strongly recommend the arterial line in any patient who is going into moderate to severe acute pancreatitis. And other dynamic parameters like stroke volume changes, the mini fluid challenge, that is 250 ml of normal saline within 10 minutes, and the passive leg raising test, which is more reliable in predicting fluid responsiveness and predicting the severity of acute pancreatitis. As far as the laboratory markers are concerned, lactates, as we know, it will increase when the aerobic cellular respiration is impaired, and elevated lactate will obviously kind of points towards a tissue hypoperfusion or hypoxia. BUN, which is useful prognostic biomarker as far as severe acute pancreatitis is concerned, and when there is a declining or a normalized BUN, you can be very sure that there is some kind of renal perfusion and the recovery of the primary disease. Hematocrit with a high fluid sequestration and increase in the viscosity, which will contribute to impaired pancreatic microcirculation, and the hematocrit will cause altered perfusion inside the pancreas. And if you have a values between 35 to 45 at 12 to 24 hours after the acute pancreatitis onset, you need to be careful. Now, how much, what should be the duration of the fluid therapy? So, the MAP, which is oral feeding, which can be initiated 12 hours after the acute pancreatitis onset if the abdominal pain is low. And so, this is, we are talking about the moderate acute pancreatitis. And as we know, when the patients are suspected to experience a volume overload, you need to stop it. Of course, moderate to severe pancreatitis, the duration of fluid therapy can be a little longer, but as I said, it has to be a individualized approach. So I think here I would like to stop, and we will discuss about the pain management in my next slides. As I said, please don't forget to like, share, and subscribe my channel, and I will see to it that I will post productive videos, educational videos in my next series. So that's all for now. Thank you very much.